What's up YouTube? Hey, it's Dr. Buck, I'm back. And in this video, we are going to watch a new medical drama. It's called Transplant. And I'm gonna react, I'm gonna watch it, comment, and react for you. The premise to this show is really good. In fact, what it is a Syrian refugee who was a physician or doctor and surgeon in Syria who comes to Canada and is not able to be a physician there, so he is actually a cook for a little while, and then eventually in the series ends up getting back into residency, which is really neat. I love this concept because this is actually one of the guys that I did residency with did this. He came from Iran, and he worked as a scrub tech for a couple years before one of the surgeons was working with him and said, you know, you're pretty good at this. Like, what did you do before? And he said, oh, I was a surgeon in Iran. And so that surgeon then helped him get into our residency. And then he did his residency again. And now he's a surgeon here in the United States, which is pretty awesome. So Sammy, I remember you, man. Thanks for teaching me all that stuff. That was awesome. Anyway, let's get to this new medical drama. It's called Transplant. It is not lost on me that he's a chef using knives. So for reference, those don't seem too deep. Your subcutaneous tissue or skin and fat is about like this. And if, big piece of glass, penetrates the anterior abdominal wall fascia, then you would be concerned that they have an intra-abdominal injury, like a small bowel or colon or a blood vessel injury or something like that. So those are pretty small, but when those patients are coming in to the ER, you have to evaluate the anterior abdominal fascia and see if it's penetrated. Sometimes actually now, so we're talking about like essentially penetrating injury, abdominal injury. So if you have a stab wound or a gunshot wound or something like that, and you think it's tangential, or you're not sure how far the knife has gone in, or you're not sure how big the knife is, because a lot of people say, I don't know how, I didn't see the person who stabbed me. What you can do is, if people that are skinny and not a lot of fat on them, you can probe that area and see if it penetrated the anterior abdominal fascia. If it doesn't, then you don't need to do any surgery to assess the bowels. If it looks pretty deep, or it's close to penetrating the anterior abdominal fascia, or on the CAT scan, or it looks like it goes into the abdomen on the CAT scan, but you can't tell, then you are kind of obligated to go and do surgery, which is either a laparotomy, opening the belly with a big incision, or laparoscopy. The alternative is to observe patients if it appears very close, like I don't think it went in, but geez, it's close. You could observe that patient for a period of time with serial abdominal examinations. If they develop peritonitis or tender abdomen, lots of pain, then that's obviously they have an injury, so then you would go and do a surgery on them. So that's kind of the algorithm for penetrating abdominal injury, like a low velocity penetrating abdominal injury. Skip a little bit here.
I don't do this now.
So what he has here is a retrobulbar hematoma, and that can be really dangerous because you can lose your sight. So what he's looks like he's about to do is do a lateral canthotomy, or open. Essentially, you have to decompress the orbit. So you have to open the sort of the eyelid on the side, and then open the orbit on the side as well. So that's a lateral canthotomy.
Hold still. I'll try to make it quick.
So it's mostly correct. You do a lateral canthotomy, but you have to open also the globe. So there's a little like ligament in there you have to cut as well. So you would have to do that. But it's pretty close. It's pretty close. I'll give it to him. And I also wanted to say the name of the show is Transplant, and I'm assuming that he's a transplant surgeon, which I have lots of transplant surgeon friends. So what's up? And it's interesting because you say, okay, well, this is trauma stuff. Like, does a transplant surgeon do that? So in general surgery residency, you have a specific amount of trauma experience you have to get. Some places get more experience. So if a general surgeon is a community hospital, there's not a lot of trauma there, or it's not a level 1 or a level 2 or even level 3 trauma, you might not get any. So you would have to go to a different institution to get your trauma, like months essentially. Some places where you do your general surgery residency, it's very heavy on trauma. They're a level 1 center, and so you're doing trauma all the time. So it depends like where you go and what residency you do and how much kind of like you're comfortable with this. This specifically, general surgeons and trauma surgeons don't do. So this is an ophthalmologist that would do this, or maybe a facial plastic surgeon, but probably just the optho guys would do this. So I have never seen one like live and never been involved in one or anything like that. I've just read about it before. So usually a trauma surgeon or a general surgeon would not have this experience.
Can you breathe?
So what he just did there was a precordial thump, and what that is just exactly what it looks like. Is you take your fist and you hit somebody's sternum really hard, and that's when it is a witnessed cardiac arrest, which maybe like they're in a VT or something, abnormal rhythm. So you're trying to start the heart again. It usually doesn't work in real life, but in TV shows, like it works a lot. I've actually witnessed one time when I was like a first year resident, I think, intern, and we were rounding and on this vascular patient, and my attending was standing there, and he thought the patient went into like a cardiac arrest or VT, and so he looked at the monitor real quick, and he was like, "Oh my God, is that VT?" And he was like, "Wham!" And he smashed this lady on the chest, and it ended up not being cardiac arrest or anything like that. So it was kind of a little bit funny because he smashed this lady on the chest for no reason, but I guess she probably doesn't think it was that funny. But things like that happen all the time. All right. So most of the time you can see a skull fracture because there's a big, huge laceration and the skin is like flapped open, and then you can see the skull. It's unlikely. So I have seen that a few times, but it's not typically in patients who are awake like this. What he's saying is patient has a skull fracture and also a blown pupil on the same side. So that's indicative of usually some kind of bleeding in the brain. So when a patient gets this injury right here, this is usually an epidural hematoma. An epidural hematoma is really dangerous because it's a artery that's bleeding right inside the skull and compressing the brain and putting pressure on the brain. And because it's an artery, it's a high pressure, and that usually doesn't stop until the brain herniates. And what I mean by that is the brain actually gets pushed out of the skull into the spinal column, and that kills the patient. So that's why he's saying, it's really dangerous, he's gonna fix him, all this stuff. So we're gonna see what it does.
You have an epidural hematoma. If I don't relieve the pressure right now, you're going to die.
So that statement, if I don't relieve the pressure right now because of the epidural hematoma, you're going to die, is a little bit misleading. The epidural hematoma is usually from the middle meningeal artery, which is the artery that runs right outside the dura mater of the brain. And although it is an artery and it's a higher pressure than like a venous bleeding, it's a smaller artery, so that does take time to build up a lot of blood. And usually, if you have a blown pupil on that side with a skull fracture, maybe you have something else going on, or maybe there's more bleeding than just typical epidural hematoma. I've seen these patients a lot, multiple patients, and it takes some time, like a few hours, for that blood to build up because that artery is kind of small. You don't have a ton of room in your brain, obviously, for a lot of blood, so a small amount of blood can cause a big problem. But it does take some time, and usually it's a couple hours. So the typical thing you see with these patients is they have a loss of consciousness. With the accident, they have a lucid period, like they're totally fine, and then they become unconscious again. And that's because the bleeding starts with the injury. Then they wake up and they're okay, but they get knocked out from the blast, or like the blow, whatever. And then as the blood builds up, they become unconscious again. So that's the typical scenario, not like, 40 seconds after the injury, you have this epidural hematoma that is, blowing your pupil. And so what the blown pupil is that the pressure on the optic nerve, which is the nerve that goes to the brain, is too much, and it's essentially paralyzing that nerve, and then the pupil, instead of the nerve actually brings the pupil down, and so you paralyze the nerve and a pupil opens up. So that's why you have a blown pupil, like what he's saying in this scenario. So
I know what I'm doing.
okay, that's not dramatic at all. So this is the treatment, well, partially the treatment of an epidural hematoma. What you really need to do is a craniotomy, which you take the flap of the skull off, and then you actually stop the bleeding of the artery, clip the artery, remove the blood, and then put this piece of skull back on, depending on how much injury they have. Because if the brain is really, really swollen bad, then you leave it off for a little bit and you put it on later. Anyway, but this is a burr hole craniotomy, so you just do a small hole in the side of the head. That is correct. Usually it's not a drill from the shed, it's a specialized drill, and the reason it's a specialized drill is because, as you can imagine, if you're drilling through bone, when you get to the other side, you have a release of resistance, and when you have a release of resistance and you don't stop, the drill goes into the brain. And so the specialized drills for burr holes have that stop resistance. The drill stops itself, so you can't go into the brain. So a little bit more tricky with this, definitely, but I guess doable, I suppose doable. I don't know, there's probably somewhere somebody has done this with a drill from the tool shed, although I'm sure you have a little bit higher risk of infection with this, so yeah. The other thing to note is that the actual recommendations from the American College of Surgeons are to not do a burr hole craniotomy if you are, say, a physician that is in a rural place or a remote location, and you have this patient and you think you have an epidural hematoma. It's better to transfer that patient as soon as humanly possible than have an inexperienced person try a burr hole craniotomy because of the problems with it. Because if you haven't done it before and if you're not experienced in surgical stuff, then you can cause more harm than good by trying this. So if you're a family physician or an ER doctor or even a general surgeon, and especially an orthopedic surgeon probably, it is currently not recommended that you try a burr hole craniotomy in a remote location. You should just transfer the patient. So that's this guy's not in a remote location. He's very close to a hospital. So really the best treatment for this is to pack the patient up as soon as possible, send him to the hospital where he can have a neurosurgeon do this in a sterile field and in a correct way so he doesn't drill a hole in his brain. All right, I like it. I think it's cool. This is pretty cool too, actually. You get the part. Cool, all right, well, that was just the beginning of the pilot episode. I think it's really good. I'm gonna watch the rest and then I'm going to do, I think, another one next week on the second episode. It's a Canadian series. I think we can all watch it. Well, you can all watch it on NBC.com. So check that out there. Let me know what you guys think of the first episode in the series. If you're watching it, I'm going to watch the rest and check it out. You guys, thanks so much for watching once again. I hope you enjoy these videos. If you do, please subscribe, like, share, all that stuff. I'll see you in the next video.